Let's get warmed up. The first question asks, how does one differentiate between subarachnoid hemorrhage and a traumatic LP as a cause of bloody CSF? You compare the red blood cell count in the first tube of CSF to the red blood cell count in the last tube. If you had a traumatic TAP, the first tube will have a lot of RBCs and the last tube will have less, maybe even none. But with a subarachnoid hemorrhage, the red blood cell count will be about the same in all of the tubes. Next, which spinal tracts convey the following information? Touch, vibration, and pressure sensation are carried by the dorsal columns. Voluntary motor command from motor cortex to the body are the corticospinal tracts. Voluntary motor command from motor cortex to the head and neck, that's the cortico-bulbar tracts. Pain and temperature sensation, those are carried by the lateral spinothalamic tracts. And important for postural adjustments and head movements, that would be the vestibulospinal tracts. They carry information about the head and body position from the vestibular apparatus to the spinal cord and eventually to the brain, so those are involved in making postural adjustments. And finally, a patient is recovering in the ICU after suffering a subdural hematoma that occurred because of a motor vehicle collision. The neurosurgery team had performed a craniotomy and drain placement to evacuate the clot. Initially, the drainage in the collection bulb had been serous. Now, however, the drainage is thick and yellow. Along with this, the patient's neurological exam has deteriorated. What is the likely cause of this clinical picture? You want to think about an abscess forming within the subdural space, so neurosurgery will need to drain the pus and culture it and clean out the wound. Let's get to that lecture.
Welcome to our video on anxiety disorders. Now, as medical students, you're already very familiar with anxiety. So say you're rounding with a particularly intimidating attending or a chief resident, and it's your turn to present a patient, and suddenly you're overcome with palpitations and sweaty palms and hyperventilation and this feeling of sheer terror. Now, I believe that anxiety is not ideal for maximal learning and recall. So I want to make this video as anxiety-free as possible. So let's close our eyes, take some deep, soothing breaths, and go to a calm, happy place. All right. Well, at least I'm not experiencing any anxiety. We're going to discuss several anxiety disorders: panic disorder, generalized anxiety disorder, specific phobias, and social anxiety disorder. We're also going to talk a little bit about the treatment of anxiety. So let's start with panic disorder. It's not terribly common, but it's fairly easy to understand, so it's a pretty good place to start. Panic disorder is where a patient has recurrent panic attacks. So a panic attack is a specific, discrete, abrupt onset of intense fear and anxiety, during which the individual experiences palpitations or tachycardia, sweating, trembling or shaking, shortness of breath, a choking sensation, chest pain, dizziness or lightheadedness, nausea, hot flashes or chills, feeling of losing control or going crazy, and fear of dying. So you need at least 4 of those symptoms to call it a panic attack. Now, panic attacks are somewhat common, and lots of things can mimic panic attacks, including medical conditions like COPD and pulmonary embolism and hyperthyroidism. Plus, patients with PTSD or depression or other anxiety disorders can experience panic attacks as well. So what makes panic disorder unique is that the panic attack is followed by a period of persistent worry about having another panic attack, or possibly maladaptive behaviors to prevent another panic attack. And this maladaptive behavior, this excessive worry, lasts at least 1 month. So if you had a panic attack, maybe it was pretty scary and you were pretty freaked out by it, and you might worry about having another one for a day or two, but over time, that fear of another panic attack is going to fade away, right? Well, in these patients with panic disorder, that intense fear goes on and on and on for at least a month, and often longer. Or maybe they had a panic attack while they were driving, and now they're going way out of their way to avoid driving. They won't go anywhere if they can't get there by bus or by walking or whatever. So that's a maladaptive behavior. And if that lasts at least a month, this could qualify as panic disorder. And we treat panic disorder with cognitive behavioral therapy to get the patient to think about their symptoms and their maladaptive behaviors rationally and to find healthier coping mechanisms. We can also use SSRIs, which work pretty well for most types of anxiety. And you can use benzodiazepines like alprazolam or lorazepam to stop the acute panic attacks, but you don't want to use these drugs very frequently because patients can become dependent on them, and they can lead to rebound anxiety when the benzo wears off. Next, let's talk about generalized anxiety disorder. So this is probably the most common anxiety disorder out there. And most people who are diagnosed with anxiety come closer to meeting the criteria for generalized anxiety disorder than any of these others. Instead of having discrete episodes of anxiety and panic attacks, people with generalized anxiety disorder are kind of anxious all the time. They have excessive anxiety and worry more days than not for at least 6 months. And it's not just worry about one particular event or activity, it's worry about multiple situations. Now, one of the key features of generalized anxiety disorder is hyperarousal. These patients feel restless or on edge or keyed up most of the time. They have difficulty concentrating, they have irritability, they can have muscle tension, difficulty sleeping, and fatigue. And this is mostly seen in young adults, and it's more common in women than in men. The most common treatments for generalized anxiety disorder are the SSRIs or the SNRIs, or possibly buspirone. Again, we're going to talk about the medications at the end of the video. And then psychotherapy, specifically cognitive behavioral therapy again, can also be helpful. Next, we have these specific phobias, in which the individual has marked fear about a particular object or activity or situation that's out of proportion to the actual danger or threat that the situation poses. I mean, it's one thing to be afraid when you find a venomous snake lurking in your house. It's not normal to become so deathly afraid of snakes that you can't enter your house by yourself. And another important feature of phobias is that the individual actively avoids any situation involving the feared situation. So these patients, for instance, can't even set foot in the zoo because they're so fearful of snakes. Now, this is one type of anxiety that we prefer to treat not with medications, but with a type of cognitive behavioral therapy called exposure therapy or systematic desensitization, where you gradually expose the patient to the feared object or situation. For example, with a person who won't go to the zoo, you may start with having them look at pictures of snakes. Then you have them imagine a visit to the zoo and talk about that in detail. Then you might ultimately have them actually visit the zoo and eventually get them to the point where they can visit a snake house or touch a snake. And all the while, you're teaching them relaxation techniques and ways to cope with the fear that they may be experiencing. Now let's talk about social anxiety disorder, which was previously called social phobia. It's kind of like a phobia related to being in certain social situations. The idea is that the patient has excessive fear of being negatively evaluated or embarrassed or humiliated by others when performing or speaking in public, or even in casual social situations like parties or meeting new people. Sometimes patients will be terrified of eating in public because they worry that people are going to watch them and judge them for the way they eat. And again, this has to cause significant distress and impairment in social or occupational functioning. I mean, it's pretty common to get nervous if you have to speak in front of a group of people or on camera in front of thousands of medical students around the world. But the point is that unless this anxiety causes significant distress and impaired functioning, it doesn't qualify as social anxiety disorder. Social anxiety disorder often begins in adolescence, and we treat it with cognitive behavioral therapy or other types of psychotherapy, which are probably about as effective as pharmacotherapy. But pharmacotherapy can include SSRIs or SNRIs, especially in those patients who have anxiety about everyday social situations who need chronic maintenance therapy. Another option is to use a benzodiazepine or a beta blocker like propranolol, especially in patients who only have anxiety in specific performance situations, so basically stage fright. So the beta blocker is going to suppress the tachycardia and some of the fight or flight symptoms caused by sympathetic activation. Patients can take these drugs on an as-needed basis if they know they're going to have to give a speech or an actor who has stage fright or whatever it is. And finally, let's talk about the medications we use to treat anxiety. Now, there's not a whole lot here, honestly. For the most part, SSRIs and SNRIs are generally first line for most anxiety disorders, just like in treating depression. So I had a psychiatry professor in medical school who used to say, depression and anxiety are the same monkey wearing a different sweater. I'm not sure I ever really figured out what exactly he meant by that, but I think it means that although the outward manifestations of depression and anxiety can be quite different, they're actually very similar deep down. So we treat both anxiety and depression with SSRIs or SNRIs. There's also buspirone, which is used as a second-line drug for treating anxiety in patients who don't respond to SSRIs or SNRIs. Buspirone can also be used in combination with SSRIs or SNRIs. Now, we really don't understand how buspirone works, but we know it has a high affinity for serotonin receptors and also some affinity for dopamine receptors. And then benzodiazepines like alprazolam and lorazepam are used fairly frequently, probably too frequently. Benzos work by increasing the frequency of opening of chloride ion channels that are normally activated by GABA. Now, contrast that with barbiturates, which act on the same GABA receptors, but barbiturates keep the channels open longer. Benzos make those GABA receptors open more frequently. And you can remember that GABA is an inhibitory CNS neurotransmitter. So GABA and benzos tend to inhibit neural firing and cause sedation and decreased anxiety. The problem is that patients can become tolerant and dependent on benzodiazepines. They can have withdrawal symptoms similar to withdrawal from alcohol, including withdrawal seizures. So benzos are fine occasionally to break an acute panic attack or for a performance-related social anxiety disorder patient, but they're really not the best chronic maintenance therapy for generalized anxiety disorder. All right, that brings us to the end of session quiz. So I want you to pause the video, answer the questions, and then we'll go through the answers together. First question, for each of the following presentations, what's the most likely diagnosis? So the patient who avoids the airport because of an excessive fear of flying, that's going to be a specific phobia. Excessive fear and worry all the time associated with irritability, insomnia, and edginess, that's generalized anxiety disorder. Anxiety about being scrutinized and critiqued when meeting new people would be social anxiety disorder. The patient who avoids all exercise because she had a panic attack at the gym 2 months ago, that's panic disorder. Remember, any anxiety disorder can cause panic attacks, but it's only panic disorder if it causes worry about future panic attacks or maladaptive behavior to avoid future panic attacks. Then the next one is excessive fear of being outside the home alone, using public transportation, and being in a crowd. Now, we didn't discuss this one specifically, but this is a type of specific phobia called agoraphobia. So agoraphobia is basically the fear of an environment, particularly an environment that you can't escape from easily. It also includes fear of being in open spaces or even fear of being in an enclosed space like a movie theater. So this is not classified as a specific phobia, but as agoraphobia. And I just wanted to make sure you'd heard of that one. Next question. How long must anxiety and worry be present to diagnose a patient with generalized anxiety disorder? 6 months. So the anxiety occurs more days than not for a period of at least 6 months. Next, what are the treatment options for generalized anxiety disorder? So you can use SSRIs. The ones proven to be effective for generalized anxiety disorder are paroxetine, sertraline, citalopram, and escitalopram. It's probably a class effect though, so any SSRI would be an acceptable choice. You can also use SNRIs like venlafaxine or duloxetine, and you can use buspirone. And the last question, what's the treatment for a specific phobia? Remember we said that was exposure therapy, which is sometimes called systematic desensitization therapy, and it's technically a type of cognitive behavioral therapy. That's it for now. I'll see you next time.
You have now entered the Symptom Zone. Feelings of impending danger. Chest pain. Shortness of breath. Dizziness. Chills or hot flashes. These are all symptoms of panic disorder.